We don't have time to go around and have everyone do introductions, so we want to use the chat for that. If you will please put in your name, the organization you're with, your job title, and what it is that you do in this space. We really want to know who our audience is. A quick background on the Texas Consortium for those of you who are new. So the consortium itself is new. We were created this year, and we're a statewide effort aimed at advancing the integration of non-medical solutions into the healthcare delivery system so that we can improve health outcomes and reduce health disparities across the state. We think the consortium is both needed and timely. There's growing momentum across the state around the integration of NMDOH into the healthcare delivery system. We're seeing health plans, providers, like you're going to hear from today, and health systems invest in non-medical interventions on behalf of their patients. And in response, a growing number of community clinics and health professionals are implementing a variety of programs to improve conditions that have a negative impact on the health of their patients and don't have anything to do with medicine. The Texas Consortium is a dedicated space specifically for all stakeholders to come together, to share, to learn, and to support what is working to build a field of practice of NMDOH in Texas. One highlight of our work that I want to mention before we get into our program is new as of last month. We have launched an NMDOH program index to catalog all of the programs across the state that are sponsored by health system organizations, health plans, providers, hospital systems, educational institutions. This index is the first of its kind that we know of anywhere, and it's a single repository of NMDOH programs, and it features abstracts of programs with searchable fields that include who's sponsoring the program, what are the drivers of health that are being impacted, are there particular targeted populations, health conditions, location, and whether or not the program has been evaluated. Our goal is for this index to serve as a resource for anyone working in the space to know about what is happening, what's working, and with what costs and what benefits. But, and here's the catch, and here's where we need your help. This index is only as robust as you help us make it. And so I'd like to invite each of you to take a look at the index. And then if your healthcare organization is doing this kind of work, we want to include it in the program index. Entering programs is really easy. Jackie from our staff can walk you through it in real time. The link to the program index is in the chat along with Jackie's email. So please, please help us build this robust database. Now let's get to today's session. Today, we're talking about patient-centered approaches for collecting NMDOH data. We will have time at the end for Q&A, but you should feel free at any time to put questions or comments into the chat. We've got people monitoring the chat the whole time, and we'll make sure to address them at the end. At the end of the webinar, we'll again put in the link to the program index in the chat and Jackie's email, because we really want to encourage you to bookmark this and get your programs into us. Now, I'm excited to introduce Ramona Perez-Torabino Whittington, who will lead our discussion today. Ramona is the Population Health and Research Director at the Texas Association of Community Health Centers. That's the large umbrella organization for the FQHCs across the state. She's been with TAC for more than 9 years, and her work mainly focuses on value-based care activities, NMDOH activities like what we're doing here today, health equity, and also TAC's health center controlled network. With no further ado, I'm turning it over to Ramona, and take it away, please.
Thank you so much, Elena. I'm really thrilled to introduce our speaker today, Palak Jalan. She is the Chief Operations Officer at Access Health Community Health Centers, which is a federally qualified community health center located in Fort Bend and Waller counties in the greater Houston area. Palak holds a bachelor's degree in dental medicine from India and a master's of public health degree from the School of Public Health at the University of Texas Health Science Center at Houston. Her role as COO makes her responsible for strategic partnerships, data operations, care coordination, expansion development, and making the health center operations more community-centered. She's instrumental in leading teams in population health and value-based care efforts, alongside convening and participating in multiple community collaboratives to conduct needs assessments, community focus groups, and prioritizing efforts around COVID-19 testing and vaccines. She has a passion for digital transformation and works with stakeholders regularly to determine the most scalable solutions. Her expertise lies in strategic integration of non-medical drivers of health into clinical practice and leading teams to achieve health and quality improvement goals. I'm really excited about today's presentation and the ensuing Q&A that will happen shortly thereafter.
Awesome. Thank you, everybody. Thanks, Ramona. Thanks, Alina. And so excited to be talking to this wonderful group of people today. I'm going to go ahead and share my screen so you all can see my presentation. Let me know if it's doing what it needs to do. Okay. Can you all see my screen? Okay, perfect. Great. So as Ramona mentioned, I'm Palak Jalan. Very proud to work alongside all of these incredible people and do this work at our FQHC, which is in the Greater Houston area. A lot of you already mentioned it in the chat, but I would love to know, even if you can write, whether you're a student, faculty, healthcare professional, or have any other role, evaluator, researcher. I think it would really help navigate today's conversation together. And I would love to keep it interactive. So if you have any questions, you want to use the Zoom raise hand function or ask any question in the chat, would be more than happy to. So can we get folks to mention in the chat what they're affiliated with? Great. I see some folks, health plan, student, mental health authority, student, hospital. That's great. Researcher, evaluator. NMDOH manager, government. Wonderful. Thanks. Please, let's keep it going. Awesome. While everybody's still typing on, I'll go into a very little bit about Access Health, so we can talk about some sort of framing approaches from where my context comes from. So as Ramona mentioned, we are an FQHC in Fort Bend and Waller counties in the Greater Houston area. A lot of you are from the great state of Texas, so you know where Houston is, but this is a little bit of context of where Fort Bend and Waller is within the Greater Houston area. To put some sort of context behind it, Fort Bend and Waller both are one of the fastest growing counties in the United States. Fort Bend is rated through the Robert Wood Johnson Foundation County Health Rankings, the 4th healthiest county in the state of Texas. The population is about to hit 1 million in Fort Bend and about 60,000 in Waller County in the next year or two. But despite all of this amazing wealth, diversity, which is one of the most diverse counties, there is still a lot of poverty, or what United Way calls ALICE, which is asset limited, income constrained yet employed. So we see almost 40% of Fort Bend, almost 40% of 1 million people, and about 50% of Waller. To show our geographic footprint, this is where we are. We have other 11 WIC locations beyond our FQHC clinical locations. And this is our patient and payer mix. So almost 20,000 patients every year. Lots of patients are minorities. 98% of patients have very low household incomes, SEAL, Medicaid, and uninsured, and a combination of that. Okay, I don't think this group does not know this, because this is the non-medical drivers of health consortium in Texas. So, but we just hear so many terms, right? Social drivers of health, social determinants of health, non-medical drivers of health, health-based equity considerations. And it can be confusing sometimes to know like what we're talking about. We say that these are the conditions in which people are born, live, work, play, that impact a wide range of health risks and health outcomes. And we use a lot of terms, but I think in Texas, HHSC, and I see some folks from HHSC, so our favorite term is NMDOH. So if I use any of these terms throughout the presentation, I think we're talking about these risk factors that really impact our health and well-being. This is a study that you may have seen very different slide decks for, but eventually we're all trying to say the same thing, right? That as a system, nationally, we are doing a lot, and healthcare is a big part of the spending, and rightly so, because it impacts our well-being and presence in the society. But in terms of spending, about 20% is what clinical care is attributed towards, but it is $3.5 trillion versus $81 billion for the rest of the 80% that you see on this pie graph. So it just shows to say, you know, like what we're doing in terms of non-medical drivers of health is really, really important. And since today's topic is about patient-centered approaches for screening for these, I would love to know, again in the chat, and I promise this is our last poll question, if your organization screens for SDOH, NMDOH, or if you recommend screening for those. So would love to hear that in the chat. And you can just do a yes or no. Wow, I'm seeing a lot of yeses. So I hope this is as interactive a conversation, since we'll all have learnings to share. It's wonderful. Okay, my slide deck is, okay, there we go. I want to share a little bit about like what we're screening for before we go into like what approaches we're using and why we're using those approaches. This is parts of the questions of our screener. And as you can see, we're talking about education and employment, benefits, housing and utilities, food, legal needs, transportation. And then we've added a few things here and there that trigger certain responses within our electronic health record. This is not to say that, you know, this is the only screener tool, but more like this is what we're using right now. In terms of a timeline of how we started doing screening and, you know, really looking at patient-centered approaches, it really started in 2018. And it is very, very hard for me to truly think that this is 5 years ago. I don't feel it's too late. It really feels relevant and as of right now, but that's when we started. And I think the first step truly was a lot of supports from Episcopal Health Foundation for the Community-Centered Health Home Initiative, and looking at the USDA 2-question food insecurity screener. So we started implementing that in December of 2018. Since it was just 2 questions, it was relatively a whole lot easier to integrate in the workflow. We're just asking 2 questions. It was done at the front desk, or check-in, as you may call it, in our clinical area. And we really got to like more than 90% screening in the first 2-3 months. And to put context, that means 90% of 20,000 patients. Very excited, you know, great. Lots of partnerships with the Houston Food Bank. And by June 2019, we had the SNAP coordinator and food pantry connections begin, fruit and vegetable prescriptions were launched. And so one of the biggest things we heard, even when we were doing the food insecurity screener, was, why are we doing this, right? And I want to harp on that throughout this conversation as to why do we screen for this? And we knew that we had, at least in terms of direct connections beyond our community advocacy piece, 3 direct ways of truly helping our patients be healthier. We changed. A lot of you are from hospitals and clinics, as I saw, or mental health centers. We changed our electronic health records in 2019. So we had a pretty old product called Success EHS, and we moved to NextGen. And NextGen came with its own like pre-existing tool. Now, mind you, there was Prepare in it. There was this pre-existing tool as a part of the workflow that was working and happening. So we started using that as a more comprehensive tool until we were ready internally. Throughout that year and a half, we were working on a clinic-developed social risk screening tool, something that you saw in the previous slide. And then we did a phased approach. We did with a couple of provider teams. We saw 2 different processes, and then we went on like clinic by clinic, department by department, so that by September of 2020, that this was fully implemented. We were doing this, full disclosure, alongside all of the COVID craziness that started in March 2020, running a lot of testing sites, vaccine sites in partnership with the county. But we had a great team that, worked through this. So 2021 too, like that implementation went on. And 2022 is when we started seeing changes, turnovers, COVID-19 is still a thing, but it just looks different than what it did in 2020. And we saw different feedback and approaches in 2022, which I think I'll share more about. And now back to square in 2023, we're reevaluating some workflows and, looking at how we started with an approach to make it more patient-centric, but even now, what else can we do to have a more patient-centered approach? And here's where I have to give like a huge shout out to our team. There's a bunch of them on this call today, Anisha, Jordan, Danish, who not only helped create this presentation, but are also really working hard this year to not only go back to our previous high standards, but really inculcate more feedback into the screening workflow and process. So this is how we do it right now. Our front desk team offers the screener to the patients. Between the time they check in and when they go to the waiting area inside the medical clinic is when the patient fills out the screener. The screener is given once every quarter because we because we see patients at least 3.5 times a year. And that was the reason to do it once every quarter. And the fact that we do want to see if something has changed or not changed within that time period. I know some approaches are doing it annually, some approaches are doing it with registration. The reason we don't do that is we have a lot of things that happen once you fill out the screener, and all of that would get impeded if we just assume that, everybody's condition is just the same during, a year's period. Our nurses or medical assistants, usually medical assistants, they enter the screener in the EHR before being seen by the provider. Then it shows up in the EHR. So during the patient encounter, you can actually see what that looks like. And then it triggers a task to our care coordination team, a wonderful group of community health workers and AmeriCorps members that will connect patients to other community resources. So that's kind of an overview or steps in the process for us. Who loves workflows and diagrams and flowcharts and Visios? So this is for Brett raised his hand. He's the data guy. So I know Ramona as well. And I think anybody who loves these workflow, we have Anisha to credit because she's created this. And I think, this is something we want to use internally for our staff so that they know exactly where they are in the process, but also to share. So it says what I'm talking about, but I think once you get a copy, this will be really helpful to know, where we do yes or no, or where do we go back in the process. Give a second for everybody to admire this workflow. Now, coming to the meat, right? These are our screening rates. And again, to put center, we see about 20,000 patients. So when we started, we were screening about 63%. At our peak, we were almost screening about 80% of 20,000, which is not bad at all, about screening about 16 to 17,000 patients every time that they're supposed to be screened. Was a big pat on our back to make sure, our workflow and process is doing what it needs to do. But then we saw some dips over the time period. And I will talk about, the successes and challenges of that approach. But this is what our screening rates look like. Talking about patient-centered approaches, I personally love to know, why are we doing something? What are we doing? What tool are we using? How are we going to do it? And then what does a quality improvement framework look like? And that's the direction that we've taken in terms of defining how to screen for SDOH or NMDOH. We had a big thing. To get buy-in, first we need to know our why. And Access Health's why was, what our mission and vision is an FQHC as a community health center, as somebody who's been in the community for almost 50 years, just know that, patients are coming with complex needs and conditions. And by addressing their medical need, we're doing a lot, but we're not doing everything we can do possible. And that's why it was important for us to screen. And we wanted to make sure us and all the staff, the leadership, the board are all on the same page of the why, because that's what rolls down the process from there on. I see a question in the chat. How did you all agree to do once a quarter? We do it annually at the time of the well visit. We discussed a couple of things. Should we do it every visit? Because there are patients that we see about 4.75 times, especially if they're seeing behavioral health, nutrition, and our focus on integrated care services. But then we thought that that will be a lot, and patients will probably not be happy filling out something or self-screening multiple times. An average patient is seen about 3.5 times a year, hence the decision to do quarterly. And just doing it annually would have meant that we would not have tracked the progress that they're making or the change or shift that's happening in their life condition during the period of the year. So that's why, we decided once a quarter. I hope that answers your question. And these are some things to think about. I know a lot of you all were yeses, so you probably have your whys too. But if anybody who's not doing it and considering, why do you want to screen the patients? It's important to know, like, okay, why absolutely do you want to screen it? Is it because TAC and Ramona are highly promoting that everybody needs to screen it? Is it because CMS is now reimbursing for it? Is it because it's really important to the patients, and that's the only way you can see patients getting healthier, and there are some incentives associated with it? Or just the staff is so frustrated that any good that we can do will go a long way? And I know the answer is not just one thing, but it's probably a combination of these things. And before this is being approached to the rest of the staff, it's really important to know the why. Why should your patients complete an additional survey, right? We all talk about like the unending paperwork when you go to a doctor's office. A lot of us do it on MyChart on our phones. Some people use their own patient portals, or whenever you go in, you're just signing stuff all the time. So if this is an additional survey or tool, why are we making it something that, the patients need to complete? And then the last thing I'd say is, like, why is it a rising concern? Whether you're a hospital, whether you're a health plan, whether you're a mental health community-based provider, or you're a clinic system, why is it a concern in your patient population, and why do you want to address it? I see another question in the chat, and I think I'll cover it, so I'll table it for now, but if not, we'll definitely come back to it. And this is another one of those things, right? What tool are you going to use? So now you've decided, this is my why. We really want to screen for it. We have everybody on the same page: leadership, board, staff, medical providers. There's a lot of tools out there. I think I saw so many folks in the chat. There's recommendations about different tools too. So I know NAC, which is our National Association of Community Health Centers, highly promotes Prepare, which is a tool that they created. It's peer reviewed now. A lot of health centers across the country are using it. So if you use something like that, the good part is that it's standardized. It probably speaks to your system. It's doing great things. There's also Accountable Health Communities tool. There's Health Leads. There's domain specific tools. So there's a lot out there. And I think a big part of that conversation is, what does standardization for screening tool look like? So we're all kind of speaking the same language. What made us, and I'll say this, like, this was a decision we made 4 or 5 years ago. And as we're evolving in 2023, it may look a little bit different for us, but what made us use a custom in-house screener versus Prepare or something that was already there was that all the other screeners were really long-winded, very hard to understand. And there was just no way to skip certain things that we wanted to skip. And you think, everything is possible. It's like a Google form or a survey, but all of us using EHRs or any tech product know that it's not as editable as you would love for it to be. You're working with certain constraints in a box, and we're trying to address that using that. So we use, because we really cared about the patient feedback that we received when we asked, would you rather like self-screen, or would you want to want somebody to talk to you about the screening process. And what we learned was that our patients much preferred self-screening or filling out a form versus having a conversation with somebody the same day of the visit, because a lot is happening. They're skipping work, they're bringing in children, they're trying to go back, a lot is happening. So conversation at that point wasn't their preference. So that's why we tailored our questions to our patient population. We wanted to use communication methods that work best for them. That's where we learned the value of paper and versus technology, how much we wanted to do it, like all tablet, all technology, that seamless integration that we would have loved to do. But we did realize that, our patients are really, really comfortable with filling out things on paper, and then we'll have to enter them electronically. We're hoping, and I think something that COVID has accelerated is that digital adaptation, alongside a lot of policy on broadband and internet access and things like that. So the goal is still to move electronically, but I think that was, again, we learned because we asked. We asked, what would be the way that it would work best for you, and then we wanted to only ask the questions. Our providers asked us this, one thing was, are we just asking these questions for data analytics, or are we actually going to do something about it? And that was the thing, like, we are going to try to not ask questions that we either don't have some resource for, or we don't have a plan for advocacy for. And that's what made us determine, what's the right question to ask. And we did want to address, literacy and comprehension barriers. So what does that look like when, we're running against a population? And I think we did a decent job, but we're doing it again. We're reviewing and revising right now as we speak. And the goal is to reduce how much content is in there and really refocus our efforts on some of these things. Okay. So discussing your what within your team, what tool do you want to use and why? It's moving way too fast. I'm going to go back. What tool do you all want to use and why? What can you do to enhance your patient experience? What communication tools are appropriate for your patient populations, and what resources are available for your patient populations? In maybe a well-developed hospital system, a lot is happening already over digital technology, and maybe those tools are available to the patients. They're already in the ER, they're already in the practice, and they're completing their consents and paperwork beforehand anyway. So maybe that process looks very different from what our process looks like. What are the tools that are appropriate? I saw a question about phone outreach versus, technological outreach. What is appropriate within your patient population? And the goal of this graphic, honestly, is to put the patient in the center of all of these decisions. Most of us, or all of us, are doing it because even though it's an additional step, we know that this is the right thing to do. So we need to think about tools, resources, patient experience, and what is it that would really impact the patients, and include patient voice in those conversations. And in that way, in deciding our how, we looked at 2 workflow integrations, modifying the existing 2-question food insecurity workflow that existed. So front desk does all the thing, and then the provider is not able to review the responses because it's all done on our practice management side. Or else splitting it, between front desk and clinical teams, where the front desk is handing out the questionnaire, but the MA is entering it and the provider can do it. So we had a wonderful intern from the UT Health School of Public Health who did this pilot process. We worked together to create a questionnaire and piloted it with certain clinical teams and took their feedback to see, alongside patient feedback, to see what was better. And hands down, we learned that splitting between front desk and clinical teams made it a more integrated experience. It was better for patients in their workflow, and it was also better for clinical teams in their workflow and front desk teams in their workflow as well. I think we've already discussed this, but how do you ensure visibility and integration? there's a lot of teams involved. And I think, we all would love to wake up to a world where everybody's always on the same page. There is no conversation, discussion, and it works great. But there's clinical team, there is front desk team, there's your community health / population health team. There are, other programs or navigators that are a part of this journey. So how does this process integrate with different teams, and how does that still support our patients, and how do we include patient feedback in the implementation approach is probably some questions we would want to ask when we think of how are you going to do this. And then continuous quality improvement. I don't think for us, or at least for us or for anybody else, this is like a process that's one and done. Anything that we implement is always, growing and learning. To share some of the great successes, I think we had our leadership buy-in from the get-go. Our CEO understood it, even when we started this 5 years ago. So kudos to Mike, but also our board was on the same page. So it really helps when you have like that kind of a supportive team, and we're not trying to, do that advocacy as well. Our staff inherently also had a buy-in, but I think the challenge was when the clinical team talks about how much additional time is this going to take during the workflow. Do we truly have resources, or are we just asking questions for the sake of asking questions? Those are not like one-time conversations or one grand presentation. I think it's definitely a work in progress for us even now. We also learned that, our two major languages for patients are English and Spanish. We were able to adjust that, but Spanish as it's spoken is different for different people, and the way it's written is different. So somebody may read it differently, and it needs to make sense differently than how the English version makes sense. So doing a literal translation to any language, having a lot more patience and native speakers from different parts was very helpful to understand, okay, what is it that's actually working in Spanish? What we also pat our backs on is scale. As you saw that, our screening rates have been up and down, but we've been able to screen almost 60 to 80% of our patients. So we haven't done it just for one group or one subset of patient population, because we know, it is all our patients that kind of need that support and help. Some of the challenges, I would say two main is staffing and turnover and modifications in EMR. So anything we're trying to change in our EHR is a very long-winded process, and it's not super easy. So even though like the process part is taken care of, if the technology is not, it takes a long time. Similarly, staff turnover, in 2022, we saw like, some staff fatigued, some staff moving on to something else, somebody leaving healthcare, somebody wanting to do something else. And this whole like wonderful group of champions that we had trained and ready to go was not there anymore. And training, another group and getting their buy-in is something that's important too. Some of the things that we're working on and doing is definitely acknowledging staff wins to improve morale, highlighting our patient success stories, because there's a lot there that's happening that is wonderful and does not get enough due credit. What is that additional value proposition from the screening process? But also talking about, like what's the purpose behind the survey and working. We're also including it we've already included it in our orientation, but we'll be including it in our onboarding for all staff members as well. So even though there is turnover, there is new staff, when they go through their training checklist, this is one of those things that, the staff is trained on. And then monthly sharing of these audit dashboards saying this is how you performed and you did, and eventually changing that into incentives or sort of, quarterly bonuses or something like that. But what we've heard, and not sure what it is in your system, but we've heard like food works great for people as an incentive. So a lot of things that has worked better is something as simple as a pizza party once a month or once a quarter. And that team really feels appreciated, for going that extra mile. So much to say that, like the patient-centric approach is something to start with, or was something to start with for us, but we're always working towards it. And as much as we would love it to be, it's one and done, it's a cycle of continuous quality improvement. And we've had a lot of approaches around rapid CQI. So we have very small, rapid cycles of improvement versus, like waiting a longer period of time. And I think what that helps us is to be nimble and making changes sooner than waiting a long time and having a much more larger infrastructure shift that needs to be made. That's my didactic part of the presentation. Here's my contact information. Please feel free to reach out if you need anything. It was such a pleasure, and I will pass it to Ramona.
Thank you so much. So we are going to have a robust Q&A period, I'm sure. I know that Jackie has just a couple of questions that she wants to ask all attendees before we get to the Q&A portion, and I'll make sure that we cover the questions that were in the chat when we do that.
Thanks very much, Ramona, and thanks, Palak, for such an outstanding example of integrating screening tools into your patient care at Access Health. I'm going to share my screen for a moment here. We have a QR code for a survey. Like Ramona said before, we open it up for audience questions. One thing that's central to us at the Texas Consortium is we want to make sure that we're catering our content to your needs and your interests. So if you scan the QR code, or I believe the link was added to the chat as an alternative, we'd like your feedback and any ideas about future offerings that we can provide from the Texas NMDOH Consortium. And we'll give you maybe like a minute or two to respond, shouldn't take too long, and we'll get back into the Q&A discussion. And once you've answered that, please feel free. I see Nancy, you've dropped a question in the chat. Keep those questions rolling in. Okay, there are only 2 questions in there, so hopefully I've given you enough time to at least look at it. If you didn't get a chance to finish it up, take some time afterwards. Again, anything you're interested in, we want to be able to create something that is valuable and will share best practices on NMDOH. I will take that QR code down now, Ramona, and pass it back over to you.
Fantastic. And I know we've got a couple of questions from earlier in the presentation and a couple that have just been dropped in. I think, Nancy, you and I were on the exact same wavelength, so I'm going to start with yours. Palak, when you were talking about your survey, you mentioned that the intent really was from the beginning to make sure that it was patient-centric. So, I'm wondering, when you're developing your processes or your policies related to the social needs data collection, where in that process development did the patient perspective occur? And how did you get that patient feedback? How did you gain their input, whether it's, beforehand, you mentioned rapid CQI cycles. Where does that patient perspective really come into play in your screening processes?
Absolutely. Like I said, we started initially. So when we did that 2-question food insecurity screener, between that and the development of our comprehensive CQI risk tool, we had staff members in the waiting lobby getting feedback from the patients on, what do they think is a better feedback. And I think that was like a quick and rapid way to get feedback while they're waiting already without asking too many questions. The second way that we did it was we have a texting system that we can use for our patients. So we asked 2 things, specifically about process, but then also like who is the most trusted stakeholder for you to have these conversations with. And we got a pretty good response. So these are some more like voluminous and scale-based responses that we received in the process for getting patient input and feedback. But other than that, we had a patient focus group as well, who informed a lot of the practices. And that focus group also included some of our employees who live in the community and identify with the demographic, so as to make it more wholesome. So I think there was two ways. One was more long form, more discussions and interviews, and one was more like point in time feedback.
Great. And so I think I'm gonna get to a couple of the questions in the chat in a moment, but I'm gonna continue this train of thought just for a second. So when you were going through your pilot process and when you were, talking about having staff in the waiting room, asking patients questions about the screening process itself to get that feedback, did you guys also incorporate or implement any kind of additional training or education for the team members that are involved as screeners? So things like motivational interviewing or being trauma informed, since a lot of these are incredibly sensitive subjects for patients.
We did. We absolutely did. I think we developed a portion of like, what's the best way to talk about this and approach this conversation. Even though we were really doing largely self screenings, I think that was our staff feedback to say that, like this is a very sensitive topic and what's the best way to approach it. So even till now, we're modifying some of that communication and what's the best way to address it. So let me take a step back. I think the first thing we did was educating everybody around the verbiage and terminology of what this means and why again. And that happened through our quarterly town halls, all staff meetings, provider improvement, provider review committee meetings, and also through like our front desk all staff meetings. So that's when we spoke about, okay, like everybody who works for a health center intuitively knows what is DHR, but maybe at that point, the terminology did not exist, right? So that was like, let's center ourselves in terms of what this is and what this means and why are we doing this. So that happened through like, I would say bombardment from all sides, like any meeting that you could see like in 2018 or 2019 that was happening that included more than 10 staff in it. We discussed what this means and why it's important for our system to do this. And why are we a community-centered health home, right? And that's how we led that conversation. Beyond that, trauma-informed care trainings for all staff, I think overall as a health center, not just for this, but like some conversations around ACEs and trauma and other things, we think it's very important. So we did an overall trauma-informed care training for all staff, which has been very, very helpful in this approach. And the staff members that eventually help with outreach and connection, let's say community health workers, et cetera, as a part of their certification and training, we make sure, they have the motivational interviewing skills, communication skills, but I think that comes with the credentialing and that's reviewed and improved every year. We have a group of 15 AmeriCorps members starting in about a week or so. And when I've seen like reviewing the packet on what their training is going to look like, motivational interviewing and trauma-informed care approaches is definitely included in that as well.
Thank you. You actually unintentionally provided your own segue to my next question. So in the fantastic workflow that you put on the screen, sort of at the very bottom of that workflow in a big blue box is when you talk about the role that the care coordinators play. That they review the received encounters to assist patients with their sort of identified needs. So a couple of questions related to this and kind of answer them in whatever flow works. So the first being, how do you do the actual care coordination outreach to the patient? I believe this was a question in the chat. Do you do it by phone? Do you have some sort of mixed methods? Is it all technology based? Are the care coordinators physically embedded in the clinics? Maybe is it your CHWs? So that's sort of the first part, but then also in connecting patients with need. So how do you actually do that connection? How do you do the referral? How do you identify the community partners that you can connect them with? And then how do you close the loop on those connections? It's my bucketed question for you.
First question is to like how we do it. It is definitely mixed method. So anytime there is one of our questions in the screener says, if any of these needs are urgent and you would like a staff member to reach out to address, it's a yes or no. And if you respond yes to that, it automatically triggers a task to our care coordination team. So it'll go in their bucket of things to do, knowing that it's urgent and high priority, and then they will address it over the phone or in person. So to answer your question, yes, they're embedded within the clinic. They are within our clinical systems. But a lot of their communication and connection can happen real time or largely outside of real time when they fill this out. So within a day too, our goal is usually 48 hours, reaching out to the patient, understanding what their needs are, if need be, inviting them in for an appointment, and moving on from that. And to answer your second question, and maybe in between, it's triaging, right? If we have 20,000 patients, and let's say you have a team of 5 to 6 care coordinators or even 20 care coordinators, it's not going to be enough ever to address all non-medical needs that come up during the patient visit. So our way of triaging is, of course, self-reported that, hey, this is urgent and I need help. But we also look at, we have a technological platform and we have AmeriCorps members also embedded in the system. That's why I said it's mixed method. So technology is kind of our first goal. We use something called the health navigation platform. And depending on two things, one is whether we have availability for the resources or not, or we also have any multiple needs. So if we are asking questions around 9 domains and you have like high needs in all of those 9 domains, we're 100% sure the first thing you need is an outreach from one of our care coordinators, and then we can lead you through the technological process. But if you're saying, food is kind of my need, I'm in that situation right now, then we'll use technology for 1 to 3 needs or 6 needs to drive you to this. So you get a video from one of our wonderful providers saying, hey, we know you visited Access Health. You mentioned in some of your visits that there are certain needs. Be on the lookout for communication from us about resources that can help you. Then our system looks at your zip code, your home address, your work address, what we have, language preferences, time of the day, and sends you like tailor-made resources from our partnerships to say like, hey, you need to go here. And you can use that code or QR code or barcode, go to that resource and get it. And it'll do that like every week. And we anticipate that 3 out of 4 times, if we've done it for a month, you'll end up going there. If you don't go, then it goes into the AmeriCorps workflow, and then AmeriCorps members reaches out and says, hey, we sent you communication. We know that you needed help. How can we help you and how do we move forward? So that's our sort of like, if we triage it in like low, medium, high risk, that's our low risk workflow. But the high risk workflow will get you an automatic contact with our care coordination team, and then they'll take it from there.
And so I imagine you guys said you had a 90% screening rate in the first couple of months, which is incredible, but also I think a really, really lofty goal for a lot of folks to reach. Given the fact that you screen and then rescreen on a quarterly basis, and you're maintaining such a high rate of screening responses, how have you communicated the need or the importance of the screening itself to your patient population? Since all of this is really dependent on patients' willingness to submit responses to your screenings.
That's a great question. And, when we ask about, let me roll back to like patient satisfaction or patient experience surveys. When we ask them about like their experience in the clinic, there's 2 places where their impact is the highest. One is with the provider in the exam room, and one is their first interaction is with the front desk staff during check-in. And I think once you're in the provider room, the provider, of course, has training, has the tools and the techniques to connect and address those things alongside the MAs. But I think at the front desk, we always, and we still do, and that's still a part of our continued educational training, which is like, why am I doing one more questionnaire, right? Why am I doing one more survey, one more consent form? And the thing is, we're not just asking these questions to ask them, but we truly care about you and we want to help address this. And we have verbiage associated with that helps our staff, and we train them on it to have those conversations with the patients.
Yeah, a great question in the chat. What are the 9 domains that you're addressing?
This is like trivia. I have to like be able to answer all of it right now. I can answer some of it. Definitely food, transportation, legal needs, housing, utilities, clothing, employment, education. So I think I covered 7 out of 9. And when I send a copy of the survey, we can talk about other 2. But these are the ones that we know we have. Utilities, I think, is one of them. these are the things that we know we have resources for and are important questions to us that can make a huge difference between, somebody being in ER for, a toe amputation versus really feeling healthy in their daily life.
I love that you said they're the things that you have resources for. I'm a big proponent of asking the questions that that you can kind of address in some capacity, so you don't build expectation that you can't meet with your patient population. But when you're identifying the resources that you have available to you, that's a huge task by itself. So how did you begin the process of really identifying those community resources that you could leverage?
Um, I think in two ways. One is like participating in existing community collaboratives that exist, and then creating where there wasn't a need. So we had great supporters in Fort Bend County Health and Human Services, and they acted as a great convener alongside us to invite other community partners into the conversation. Um, and I think overall, Greater Houston area, Fort Bend and Waller, people are very interested in collaborating, but what we soon realized is there wasn't the need for like one more regular meeting. We're meeting too many times in a month already to use one more meeting unless there was a specific need to have one. So it was a combination of resources that we already knew were out there. So giving you examples, like United Way hosts something called Fort Bend Connect. All Fort Bend organizations, a lot of nonprofits attend that. Two local foundations host their like community convenings almost every month, and there's a lot of like other nonprofits who are community partners who come to that. So we had so many common linkages that we used existing platforms to talk about like linking together and build upon existing relationships. And just tell you, and I think our team right now is great too. I don't think anybody thinks of it as a closed door. I've made so many cold calls earlier, and I think our team still does and shows up as staff changes and we reach folks. So it's always great to know somebody, right? And I think we were very lucky and we're grateful. We live in a community where we know already a lot of partners and people, but I don't think there is any shame in reaching out to partners. I think 5 out of 10 times they're probably just busy, and as nonprofits they have a lot on their plate, but they do appreciate somebody making that outreach and connection and are supportive. It just takes longer, and when you have a connection, I think TAC is a great convener. We have other nonprofit organizations or even RICE or EHF that have been great conveners. It brings people together, and we have existing places to connect with. So we did it both ways, but I think we were definitely already in rooms where these conversations were happening and partners were already there.
Fantastic. So we've got time for one more question, and I think I'm going to take executive privilege on this one, given that I love your workflows and I love data so much. Just really briefly, can you tell us what role data analytics has played in enhancing your provider buy-in, enhancing community buy-in? What I mean by that is the ability to provide data to your providers on the impact of the screening itself. So screening takes a while, and reviewing those screenings can take some time, but I think data also plays a big role in this.
Absolutely. In Ramona, such a great question, because we all think that it's 3 steps in the process, really easy to do, but what takes the most thought process is building that data infrastructure behind it. And that data infrastructure is based on how your EHR workflow is, if that's what you're using. And if you're doing a third party, system or screening, then it's relatively more independent. So I'll tell you what our aspiration is and what we're working on right now, because I think that's where we would love to be. What we've done in the past is we've looked at screening rates and generation rates. So how many are given out, how many are entered, what is the impact, how many patients were helped, and shared that in regular quarterly meetings that we have together. And that showcases like some of the impact we have. Using that data for social media marketing, I think that's great too, because that speaks of the stories, right? There's data that is concrete and there is data that tells a story. And definitely, data that tells a story has more power for impacting people's emotions beyond that. And I think our providers bought in knowing that we were truly helping patients. So even today, when they're like, okay, why are we doing it? Hey, there's a team to actually help everybody, and there's a system and process. So we're not just asking for the sake of asking. But right now, what we're working on something is called like audit dashboard. So for all MAs, all providers, all front desk staff, like their own personalized, this is how much you were able to do. This is what you were able to achieve. This is what the impact of your work has been. And sharing that data monthly with your own personal dashboard is something that we're working on right now. And we're very excited about being able to share that data with not just teams, which is what we've done in the past, like pediatrics at Richmond or, pediatrics at Missouri City, but really individualized. This is the impact of your own team.
I love that. I think I love the idea of not just showing the impact of a center, but being able to connect a staff member with specific improvements or impact in a community is sort of what sustains us as nonprofit health institutions. Palak, thank you so much for your presentation. I think that you've given us a lot to think about. I know that I still have a million questions, and I will probably independently reach out to you. I encourage participants to reach out to Palak or to Jackie or to myself if you've got questions. And I really thank everyone for joining us. With that, I'm going to pass it back to Jackie so that she can review the survey again.
Thank you so much, Ramona. And yes, to echo that, thank you, Palak. This was a wonderful discussion, very robust, and I'm sure we all had plenty of lessons to learn from y'all's experience. As you see, I've put the survey back up. So before you guys run off, please, please, please give us feedback. We're able to create content like this because we hear from you about what would be interesting and valuable to your own experience in this space of NMDOH. As Elena mentioned, separately, our program index is live, and if you take this survey, it will redirect you to our website where you can access that program index. I hope to hear from all of you. I expect to hear from at least a handful of you. Reach out to me, and I'd love to get your programs submitted. So we'll keep this up on the screen. Give us your feedback. And again, thank you so much for taking the time to join us today.
Thank you. It was a pleasure for me as well. Thank you.